So today's topic is HYPHEMA. So what is HYPHEMA? Definition is the collection of blood in the anterior chamber So from where does this blood come from? So this blood can come due to tears in the anterior face of ciliary body along with the disruption of major arterial circle or from recurrent choroidal arteries or the ciliary body veins or from the rupture of iris vessels, right? So this is the thing, and this bleeding, so depending upon how much anterior chamber is filled, it is graded as microscopic, so which is only visible microscopically, in which there is no layering of blood and there is only circulating RBCs only. There is no layering of blood. And in grade 1, the blood fills less than 1/3 of the anterior chamber. In grade 2, it is 1/3 to half of the anterior chamber. In grade 3, it is more than half but less than full. And in grade 4, it is total HYPHEMA. So when there is total HYPHEMA, the anterior chamber is filled with blood completely, and when this blood turns into an old one, then this becomes a brownish red or blackish red in color. So that is called as 8 ball or black ball HYPHEMA, right? So that is the grading of the HYPHEMA. Okay. Next, coming to the bleeding. So how does this bleeding stop? So the bleeding, it can stop usually within 2 to 5 days. So that's why we have to wait minimum of 4 days before doing any intervention in these cases. So because there is a chance of rebleed. So this stops due to IOP tamponade, vascular spasm, and formation of fibrin clot. So rebleed can occur within 2 to 5 days. So this occurs due to fibrinolysis, reduction of IOP, and clot retraction. Alright, so coming to another thing. So this total HYPHEMAs and this bleeding can block the trabecular meshwork and lead to glaucomas. So coming to glaucoma here. So there is early glaucoma or late glaucoma. So the etiology is different. So this is a secondary glaucoma because this is secondary to bleed, or there is some pathology inside the eye, right? So the early glaucoma is due to the blockage of trabecular meshwork by the red blood cells, or in case of the large hyphemas, there is pupillary block. And the late glaucoma is due to angle fibrosis, hemosiderosis, formation of this pupillary block in large hyphemas. It can lead to the formation of peripheral anterior synechiae, and there can be angle recession in case of traumas with ciliary body disruption, right? Yes. Then coming to the etiology. So the most common is ocular trauma. There can be a surgical trauma in which there is manipulation of the iris is more, and it can be spontaneous in cases of hematological diseases like hemophilias, sickle cell anemia, sickle cell traits, right? And in case of ocular diseases in which there is neovascularization of the iris or the angle, so it can occur in diabetics. Okay, so in case of herpes simplex or the herpes zoster, iridocyclitis, and in case of tumors like juvenile xanthogranuloma, we have melanomas of iris, and there is a UG head syndrome, uveitis, glaucoma, HYPHEMA syndrome. So in these cases there is formation of hyphemas, right? Then coming to the management. So what are the aims of the management? So we have 4 aims. So the first one is to minimize the bleed, reduce the bleed, the chances of bleeding. We have to control the pressure. We have to perform, make sure that there is no corneal blood staining. And we have to remove the blood, right, from the AC. So these are the aims of management, right? So how do we reduce the chances of rebleed? So so to prevent the chances of rebleeding, we have to have some things like head elevation, so this we can do either with the help of drugs. So we can first start with supportive therapy. So in supportive therapy we have to elevate the head end and be in the supine position. We have to reduce the pain and inflammation. So for that we have to give topical steroids and cycloplegics. Atropine can be given. Then if the patient is using any drugs which reduces clotting and all, so we have to stop those, like we have to stop any aspirin and NSAIDs, right? So then to reduce the chances of rebleeding, what we can do is we have to give anti-fibrinolytic agents. In which we have aminocaproic acid, ACA, and we have tranexamic acid. So what is the mechanism of action? So these are lysine analogs. They bind to the lysine binding sites on plasmin, which prevents plasmin from attacking the fibrin clot. So it prevents clot dissolution. Okay, so this is the thing. So how much can this, what is the dose of this aminocaproic acid? So this can be given 50 mg per kg 4th hourly. Maximum is 30 grams per day. And tranexamic acid is 25 mg per kg. It can be given TID, and the maximum is 1.5 grams per day. So these are oral medications. So what are the side effects of these? So they can be nausea, vomiting, postural hypotension, and these are contraindicated in cases of hemophilia and renal failure, right? So we are done with the one reduced bleeding. Then we have to control the IOP. So how do we do this? First, with the help of anti-glaucoma medications. So we can give beta blockers, topical, 0.5% timolol, BD. Then we can give systemic drugs. We have aqueous suppressants and hyperosmotic agents. We have this acetazolamide. So these are carbonic anhydrase inhibitors, can be given 5 mg per kg, that is 250 mg QID. In hyperosmotic agents, isosorbide 45%, oral glycerol 50%, or IV mannitol 10 to 20%. So we have to measure IOP. Hourly till the IOP comes to 24 mm of Hg. So if these medications and all don't work, then we have to go for surgeries. So surgery is usually indicated in cases of complete hyphemas, total hyphemas, right? So we have to perform trabeculectomy and iridectomy for large hyphemas. So trab is done to increase the filtration, and iridectomy is done to inhibit the pupillary block. Then we have, how do we reduce this corneal blood staining? So it cannot be reduced, it can be just be prevented, right? How do we control this? Then we have the management of hyphema. So how do we manage this hyphema? So we can either do a AC washout with INA or AC paracentesis. So we can use a 30 gauge needle and at 2 planes. So if we consider this, at the iris plane we have to give a clear corneal incision. So here is one and here is one. So 2 stab incisions are needed. And we can also perform automated hyphectomy and clot expression and removal. So this can be done on 4th or 5th days when there is a formation of clot. So these are done early and this is done late. So here we were speaking about corneal blood staining. We will see it comes under the indications of surgery. So what are the indications of surgical management? So we have this IOP criteria and we have corneal blood staining criteria. So in IOP criteria we have IOP greater than or equal to 50 mmHg for 5 days or greater than and equal to 35 mm of Hg for 7 days. And along with this, in case of patients who have bleeding disorders or who have pre-existing glaucoma and who have optic atrophy or disc at risk, so these require early intervention. And coming to the corneal blood staining criteria, so in case of total HYPHEMAs with IOP greater than equal to 25 mm of Hg for 5 days at earliest sign of corneal blood staining, and in case of HYPHEMA which fails to resolve to less than 50% of AC volume by 8 days. In all these cases we have to give this corneal blood staining criteria. So what are the surgeries? So we have discussed already over here the management of HYPHEMA. So these are the surgical interventions, and the other interventions which can also be done is irrigation of anterior chamber with clot dissolvers like streptokinase. This is 5000 international unit per ml, and we can also use human TPA, that is tissue plasminogen activator, 6 to 25 micrograms intracamerally. Right? So this was regarding the management of HYPHEMA. Okay, so these are the surgical interventions. So in the surgeries we have to perform either washout, paracentesis, hyphthomatic, hyphectomy or expression and remover, and along with that we can also perform these traps. Okay. Thank you.